Hello, and welcome back to the official Indian Journal of Anaesthesia podcast, where we'll be sharing insights from the authors of two very interesting articles published in the most recent July issue of the Indian Journal of Anaesthesia. I'm your host for this episode, Dr. Gautam Reddy, and I'll be joined by my co host, Dr. Rashmi. So let's just move right along and let's dive into the details of these articles. Firstly, I would like to introduce Dr. Sukhyanti, who is a professor at Maulana Azad Medical College in the Department of Anesthesia, and who is the co-author of the first article in Focus today. The article is titled The Comparison of BlockBuster Laryngeal Mask Airway and AirQ Intubating Laryngeal Airway as a conduit for fiber-optic bronchoscopy-guided tracheal intubation in pediatric patients. It's a randomized comparative study and it was published in the most recent issue. Ma'am, to begin, could you please describe the fundamental structural differences between these two devices? That's the BlockBuster and the AirQ, and what makes each of these designs quite unique?
Okay, so both the LMA Blockbuster and AirQ, they have been specifically designed to facilitate the tracheal intubation through them. So AirQ was introduced in the year 2005 and it is been in clinical use since around 2011. So the main feature of this supraglottic device is that it has a short and wide airway channel along with a preform curvature. The cuff of the device has a mask hill to facilitate the better sealing, and the ventilating orifice is keyhole shape to prevent the downfolding episodes of the epiglottic. Also, this device is provided with a detachable connector to facilitate the easy passage of the endotracheal tube and the fiber optic cable. This is provided with a stabilizing rod to facilitate the removal of the endotracheal tube after the device has been placed. So there are various versions of the AirQ. We use the standard AirQ, that is the curved tube, which has to be inflated to achieve the seal. The LMA Blockbuster is comparatively a newer device and it has been introduced in the year 2002. Similar to the AirQ device, it has got the short and wide airway channel and it is also has a preform curvature. But the difference is that the airway channel is wider compared to the AirQ and the curvature is also more angulated. In AirQ, we have just the airway channel, the standard one, whereas in the LMA Blockbuster, it is a second generation supraglottic device. There is a gastric channel which runs side by side, and also there is a integrated bite block, which is with this device. So one of the interesting feature of LMA Blockbuster is that it is supplied with a flexometallic tracheal tube, which has got the Parker flex tube, and also there is a stabilizing rod. So both of these devices, basically, they have been designed for facilitating the tracheal intubation through them.
Thank you, ma'am. On understanding how these two devices are different, I would just like to know why this study was selected and what its translational value is in the field of anesthesia.
Okay, so we selected this device because nowadays we know that there are plenty of supraglottic devices available for use in adults as well as children. So these supraglottic devices have got various features. Some of them are cuffless, some has got the longer length of the airway tube, and there is not much consensus on which type of the supraglottic device is suitable for performing the fiber optic guided intubation. So this become more, important in pediatric patients because patients, fiber optic guided intubation is not commonly performed. Many of us are not working as a full-time pediatric anesthesiologist. We face with the difficult airway scenarios in children not very frequently. So literature have suggested that the available supraglottic device, when they are compared, there is not much difference in terms of performing or placement of the endotracheal tube. But after successful placement of the endotracheal tube, when the conduit is removed over the tube, there are serious concerns that are there with the available supraglottic devices. And among the available devices, the AirQ has got the most favorable safety profile in terms of removal of the conduit. So we designed this study with aim to compare the safety profile of LMA Blockbuster to AirQ in terms of the characteristics when this device is removed after successful placement of the device.
Right now, it just nicely brings us along to the next question, which was how does the whole anatomy of the pediatric airway also influence the choice and design of these supraglottic devices?
So we all are aware of the fact that pediatric patients are not similar to the adult. They have got the different anatomy and different physiology. So when we look at the fiber optic guided intubation through the supraglottic devices, there are some anatomical factors that we need to be aware of. Like there can be mismatch between the outer diameter of the pediatric endotracheal tube and the inner diameter of the airway channel of the supraglottic device. Also, especially in small children, what happens that when the conduit is removed after successful placement of the tracheal tube, the entire length of the endotracheal tube can get sometime embedded within the length of the airway channel. So the removal becomes really difficult. There can be difficulty in controlling the endotracheal tube. There are chances that the tube might migrate out of the glottic inlet. We may lose the airway. So these are the differences that we need to be aware of while going for fiber optic guided intubation through a supraglottic conduit in cases of pediatric patients.
Also, ma'am, as you mentioned, both the groups use different endotracheal tubes. I think the BlockBuster is the provided Parker Flex tip. And for the AirQ, you've been using the PVC ETT. So how might this variation affect the comparability of intubation ease or even the duration?
Okay, we use different kind of the endotracheal tube in the study groups because the main reason was that only LMA blockbuster was supplied with the Parker Flex tube, and PVC tube is the most commonly tube that we use for intubation through other supraglottic devices. The Parker Flex tube was designed so as to prevent the instances where there can be impingement of tracheal tube to the airway structure during while it is railroaded down the trachea. But this promising feature of Parker Flex tube has not been consistently demonstrated in the clinical studies. In our study, we do not encounter any instances where the tracheal tube was impinging onto any airway structures. This was mostly because both the supraglottic devices, they provided the excellent view of the glottic inlet. In almost all the cases, in the majority of the cases, we were able to visualize either the entire glottic length or the posterior part of it. So because of this, there were no episodes of impingement even when we were using the different kind of the endotracheal tube.
Study also found a statistically significant difference in the conduit removal time, which is about 2 seconds faster with Blockbuster. Do you think this difference has a clinical relevance in pediatric population especially?
During the removal phase of the conduit, you know that we need to disconnect the anesthesia breathing circuit. The patient will remain apneic, and we know that the pediatric patient, they tend to desaturate faster. So obviously, time has really great concern at the time of the removal of the conduit. We found that between the two groups, there was a difference of 2 seconds, which was statistically significant. But we feel that this 2 second is not much of clinical concern in real clinical scenarios.
Yes, ma'am. Ma'am, also, there were no adverse events which occurred during the conduit removal in either of the groups. Were you surprised by this? And if so, what were the adverse events you were most concerned about based on like previous literature that you've seen?
We were not actually surprised by the results of the study because, you know, both these devices were designed so that to facilitate the tracheal intubation through them. You know, both of the which endotracheal, which kind of the supraglottic device is preferred for fiber optic guided intubation. Those who have a wide diameter of the airway channel and those who are having the short length of the airway channel. So both these features were present in both these devices, and both of them were provided with the stabilizing rod. So actually, we were expecting that both of the devices were safe in terms of the removal of the conduit. But if you look at the literature, the other kind of the supraglottic devices which were compared with the AirQ, specifically devices like IGEL, which is very commonly used. But IGEL, when compared with the AirQ, was found to have various side effects at the time of the removal of the conduit. Like there was difficulty in controlling the endotracheal tube. There were more instances where the tube was migrating out of the glottic inlet. There was dislodgement. So this was because of the physical feature of the IGEL. You know that the airway channel is narrower compared to the AirQ. Also, IGEL is comparatively a longer kind of the supraglottic device. So we were not surprised by the findings of our study.
That's great, ma'am. Which also shows that we can safely use these devices in pediatric populations. Also, both the devices required operator experience with at least 20 previous uses. Is this learning curve a bit steep for these device use? And what advice would you give to departments considering adding this to their difficult airway armamentarium?
The learning curve for both the devices was not steep at all, you know, because both of the devices are available with a preformed curvature that will facilitate their easy placement. And also because in our department, we have been using a different kind of the supraglottic devices since many years. So the operators are really comfortable with that. So definitely these two devices are very specific in terms if other departments are looking at what type of the supraglottic devices that they should have, because among all the available devices, these particular devices are, they have got the best profile to facilitate the placement of the supraglottic devices. So they can go for either of them. Both of them have similar performance.
A cost consideration was something which wasn't discussed in your paper, but how do these devices compare economically, and how might this factor into institutional decision making?
I think cost of both the devices are nearly same. AirQ is a single-use device, and one piece of the AirQ is available for 3,000 to 4,000. And similarly, LMA Blockbuster along with the Parker Flex tube is available for 6,000 rupees. So nearly the difference is only of 2,000 rupees. So depending on their preferences, the department can go for either of these. But I feel that LMA Blockbuster has got slightly upper hand because it is exclusively provided with a endotracheal tube that has got the better safety profile.
And what was the single most important clinical pearl you would want your listeners to take away from this study?
So whenever we are dealing with a difficult pediatric airway, there are two options that are available nowadays. One is the video laryngoscopy-guided intubation that is also nowadays very popular, or performing the fiber optic intubation through a supraglottic conduit. So there is a study in 2017 based on the analysis of the pediatric difficult intubation registry. So that included thousands of patients, and they found that video laryngoscopy compare when it is compared with the fiber optic intubation has got the upper end, because when we perform the supraglottic airway device assisted fiber optic intubation, it will relieve the airway obstruction that occurs with induction of the anesthesia, or even when we need to give some kind of the sedation to the patient. So supraglottic devices will take care of that, and there are less chances of hypoxemia, and this will increase the chances of success rate with the device to opt for. So one need to be, clear regarding the physical feature of the supraglottic device that should be selected. So one should be recognize this factor. The supraglottic device having a wide bore airway channel, those who had got the shorter length of the airway lumen are preferable for guiding the fiber optic intubation in these patients. So I just want readers to recognize these features which makes a supraglottic device suitable for fiber optic guided intubation.
And lastly, were there any limitations in the study which would warrant future studies, madam?
Yeah, so when we started this study, there was no previous study available on the similar topic. And by the time we completed this, there was one study which was published in the pediatric anesthesia. So we performed our study as a pilot study. So larger studies are required for further differentiating between the two devices. And also we use the different kind of the endotracheal tube. So future studies should be performed keeping the type of the same endotracheal tube. And also in our study, we excluded the children who has age less than 1 years. So we know that in smaller children, they have got the different anatomy altogether, and also they tend to desaturate faster. So future studies should also be performed on smaller children, those who are aging less than 1 year.
Thank you so much, madam. So I had a lovely time reading your article when it had come out in the July issue, and hearing all the discussion from you as to what all important questions we had regarding the things were all taken care of. So now I would hand over the mic to Dr. Rashmi, who will be taking over the second article for today.
Thank you, doctors, for such an informative questionnaire. I'm Dr. Rashmi, and I would like to deal with the article regarding the effect of prophylactic phenylephrine versus norepinephrine on feto-maternal outcomes in caesarean delivery under neuraxial anesthesia. It's a systematic review and meta-analysis with trial sequential analysis. And for this, we have with us Dr. Sharmishtha Pathak, who is an assistant professor at anesthesiology and pain medicine and critical care at AIIMS Delhi. Welcome, doctor, on board.
Thank you, Rashmi, for inviting me.
Thank you, ma'am. It's a pleasure. Now, ma'am, coming to the first question, what inspired you to conduct this head-to-head comparison between phenylephrine and norepinephrine in the context of cesarean delivery and neuraxial anesthesia? Did you feel that there was a gap in this existing clinical practice or any conflict in evidence in literature?
Yeah. So basically, when we were looking through the literature, there is a lot of literature available on this particular topic, comparison of various vasopressors in pregnant patients undergoing spinal for cesarean section. But
Yes.
however, we found that the literature was either focusing on treatment of hypertension, or it was focusing only on the maternal hemodynamic profile, the effects on maternal hemodynamic profile.
Right.
It was not including the effect on the fetal outcome or the neonatal outcomes. The neonatal, if outcome was included, acid-base effects were missing. So we decided to conduct this meta-analysis along with the trial sequential analysis to comprehensively analyze the effect of prophylactic use of norepinephrine versus phenylephrine in understanding its effect on both the maternal hemodynamic profile as well as the neonatal outcome in terms of acid base status of the fetus and the APGAR scores.
Nice, ma'am.
So
It's
that
good
was
to
our
know that.
primary idea behind.
Okay, it is good to know that the bridging gap is there where both the fetal and the maternal outcomes is taken care of. From your analysis, what would you say is the most clinically meaningful difference between these two vasopressors in terms of fetal-maternal safety and outcomes, ma'am?
So our analysis revealed that the most clinically meaningful difference appeared in the maternal hemodynamics. That is the effect on specifically on bradycardia. So we found that norepinephrine, when used prophylactically, is significantly reducing the incidence of bradycardia. In the terms that incidence of bradycardia was nearly halved as compared to phenylephrine. So this provided a safer maternal hemodynamic profile, thus reducing the incidence of decreased cardiac output, hypotensions, and reflex hypertension as well. Although the effect of both the vasopressors was comparable on fetal outcomes, whether it was umbilical artery and vein pH or the APGAR scores, but still it was found that the safer maternal hemodynamic profile can ultimately provide a safer fetal profile in terms of no effects on the uterus and the fetal blood.
So, are you telling us that the norepinephrine had an upper hand?
Yeah, definitely. Norepinephrine, based on our analysis, had an upper hand over phenylephrine, especially when it was being used as prophylactic agent. So it was producing lesser incidence of bradycardia, lesser incidence of reflex hypertension, which was seen commonly in the phenylephrine group, which was causing a high incidence of reflex hypertensions.
Right.
And as we know, in the pregnant patients, not only we want to avoid hypotension, we also want to avoid sudden hypertensive episodes, as even sudden hypertensive episodes in these particularly in this patient group, can affect the outcomes. And when we are getting surgeries done for patients who have other cardiac conditions associated with pregnancy, then we want to avoid these incidences further. So definitely norepinephrine was having a safer profile as compared to phenylephrine.
Yes, it's nice to know that prophylactically we are prepared depending on the patient according to your study. So your meta-analysis included a trial sequential analysis, which is not commonly used in all systematic reviews. Ma'am, could you briefly explain why you choose to include TSA and what additional value it brought to your findings?
You're absolutely right. Trial sequential analysis is normally not included. Initially, we had also thought of conducting a systematic review and meta-analysis, but when we were doing a literature search to find out the lacunae, we realized that not all studies are comparing the prophylactic use, both on maternal profile and fetal profile. And we realized that this topic has a lot of literature available. Like you would see in our article, we have included 70.
Yes, ma'am.
So we have a lot of literature available. And trial sequential analysis is something in very basic terms will help you in understanding whether for a particular outcome have you achieved the appropriate sample size which is required to test that outcome, or do you still need to examine further. So when you apply trial sequential analysis to any systematic review and meta-analysis, you are able to pinpoint a particular outcome. For example, in our case, we were able to find out that the effect on bradycardia is not only clinically significant based on meta-analysis. Actually, we do not require any further studies assessing this particular outcome because we've achieved the required sample size.
Right.
So any further study is going to reveal the same outcome.
Yes.
That norepinephrine is better than phenylephrine.
Phenylephrine.
When we look at other outcomes like umbilical artery pH and umbilical vein pH or the Apgar scores, although the present meta-analysis tells us that there is no clinically significant difference, but when you look at it from the point of view of the trial sequential analysis, you will realize that actually the appropriate sample size is still to be achieved. So we still require robust clinical studies to find out these effects and thus come to a conclusive evidence whether norepinephrine or phenylephrine is affecting the fetal outcome or not.
Right.
So that is where trial sequential analysis becomes important.
Were there any major challenges in selecting and comparing studies across different hospital protocols, like in your meta-analysis? And how did you address this heterogeneity?
Yes. So, yes, we definitely faced challenges because every study conducted mainly was based on a particular hospital performing, how they perform the caesarean sections, how they are administering the drugs. So, the drug dosages were different in all the studies. The way of administering drugs, whether they were giving it as bolus or infusions, or whether the fluid administration, whether it was preloaded or co-loaded, or they were doing after loading. The heterogeneity of population, some were including only normal pregnancies, some included singleton pregnancies, twin pregnancies, eclamptic patients. So yes, we faced a lot of difficulty when we were trying to include these studies and doing analysis. What we thought how to remove these difficulties was, first of all, we applied random effects model, which is a very basic correction you should apply whenever you're facing a lot of heterogeneity. It helps in reducing that. Right. Secondly, we decided to perform subgroup analysis. So we had a lot of subgroup analysis, like comparing amongst all the population, comparing between bolus versus infusion, like co-loading versus preloading, then singleton pregnancies versus twin pregnancies. So when you add subgroup analysis to your main analysis, it helps in reducing the bias further. Then we another reason for doing trial sequential analysis was high heterogeneity. So TSA helped us in actually understanding that yes, this outcome has a strong evidence and does not require further basis. Also, there was application of grade methodology. So we were able to point out that yes, this analysis, this heading which we have taken has a high heterogeneity or is a high evidence group or a low evidence or an inconsistent group. So these four methods were basically employed by us to remove the heterogeneity which we faced.
So it's nice to hear, ma'am. Of course, with so many factors and heterogeneity, obviously it was a task, but I think with TSA and other methodology, you all have pulled it off really well. Lastly, ma'am, were there any limitations in the existing literature that you believe this future RCT should address to perform better?
The limitations in existing literature I would point out are basically the lack of homogeneity in defining our protocols. For example, in the studies which we have included, they have various definitions of hypotension. So some are defining hypotension as less than 80 systolic, as 90 systolic. So that we also had problems in understanding how to define hypotension because every study was defining it separately. Then definitions of bradycardia was separate in the studies, whether they were using drugs as bolus or as infusion. So there was no consistency in the protocols which we found. So if we could formulate a randomized control trial with protocols which are consistent with definitions for bradycardia, hypotension, or using a bolus dose, or defining when you are going to use, what rescue methods you are going to use. Some studies lagged in defining proper rescue methods as to if hypotension occurs despite the prophylaxis, what would be the rescue treatment you would be offering. Lack of measurement of neonatal outcomes. There were studies, some studies included only UAPH, that is umbilical artery pH, or some studies just reported Apgar scores. So there was no uniformity in the reporting of outcomes. So a protocol which actually focuses on the acid-base status of the fetus, not only the pH, but also base access, which is now becoming more and more popular tool for understanding the acid-base status. So if these problems are addressed and a protocol is formed addressing these problems, I think that would be a better way to arrive at better conclusions in relations to the outcomes which we are still not understanding well, or we are still inconsistent in answering the questions to.
Thank you, ma'am. But I'm sure with the protocol which you all have formed, majority of the doubts would have been cleared with respect to, the measurement of the pH and the base excess which you all have done. Thank you so much for answering these questions, ma'am.
Thank you.
Thank you, ma'am. So thank you guys for joining us on this insightful journey into current anesthesia practices. Until next time, stay curious, stay informed, and we look forward to meeting you again in our next episode. Thank you all.
Thank you very much. Thank you.
Thank you very much.
Thank you.